Well, welcome. I'm Toni Gansel. I'm Dean of the School of Medicine and Vice President for Academic Medical Affairs at the University of Louisville, and it is my pleasure to welcome you back to the afternoon session on behalf of the AHC. To kickstart this afternoon, we have a session on the future of faculty practice plans, innovative solutions, and imaginative approaches. And we are going to hear from four wonderful panelists from diverse backgrounds and diverse academic health centers who will share their wisdom and their expertise on the subject with us. I'd like to introduce those panelists to you now, and I urge you to access the app and access their bios because they truly are very impressive. We have Dr. Sam Hawgood, who is the Chancellor of the University of California at San Francisco. We have Dr. Rob Romas, who is Dean of the Joe R. and Teresa Lozano Long School of Medicine and Vice President for Medical Affairs at UT Health San Antonio. Dr. Cam Patterson, Chancellor of the University of Arkansas for Medical Sciences, and Dr. Brian Strohm, Chancellor and University Professor at Rutgers Biomedical and Health Sciences and Executive Vice President for Health Affairs for Rutgers University. I'd like to remind you that if you would like to ask a question, please use the Q&A feature at the bottom of the screen, and we will take those questions at the end of the four presentations. So again, welcome. Dr. Hawgood, I believe you're going to get us started, and we look forward to hearing your presentation. Dr. Hawgood.
Thank you, Toni, and I will just share my screen here. Thank you. So in just a brief few minutes, I'm going to walk you through a journey that we have been on over the last roughly 6 years. And we very intentionally, back in 2014, as part of a 5-year strategic planning exercise, determined that we needed to move from being an academic health center to an academic health system and eventually to an academic health network. And we are on that journey, but we decided that from a strategic point of view, the most critical thing that we could do back in 2014, 2015 was to achieve very, very close alignment between the health center executive team and the School of Medicine physician practice plan. At that time, I was the Dean of the School of Medicine and President of the Faculty Practice Plan. And so we spent roughly a year working out what that alignment looked like. And I'm going to briefly talk about the two major elements of that. One is a complete change in the governance of the health side of the university. And the other is the alignment of the funds flow between what we then used to call the medical center and the faculty practice plan. Our key objectives in this were to strengthen our ability to act with one voice with our external partners, simplify decision-making once a strategy had been determined, actually to strengthen considerably the roles of the clinical chairs in clinical strategy and policy making, strengthen the role of executive management in enhancing our academic mission, to make sure that the leadership of what became UCSF Health was completely aligned with the academic mission, seamless integration of services around the patient, with the patient in the middle of all of our services, and to achieve accountability at every point of our healthcare system so that we could execute in an efficient and forceful way. I won't show you the org chart pre the governance change because it probably would take 2 or 3 slides to get the complexity of it in there, but this is where we ended up. The chancellor in the UC system, the way our governance is organized, is delegated the authority of what a traditional board for a hospital would look like. So the Chancellor is the governing agency, and then we created an Office of UCSF Health that had the Vice Chancellor, Dean of the School of Medicine, and the President and CEO of the health system in a single office. An executive committee that had a predominance of clinical chairs that were selected by the chairs, 6 chairs out of 20 clinical departments, and then a unified health leadership council that had both the previous medical center executives, chief nursing officer, chief financial officer, chief medical officer, etc., with all 20 clinical chairs. And that's the governance of both the faculty practice plan and the health system. And then we have a very important external advisory council that advises the office of the health system. Having realigned the governance, we then wanted to realign the way funds flowed between previously the medical center and the faculty practice and the dean of the School of Medicine. Again, what we'll be trying to fix at that time, there was clear misalignment in revenue streams. There were very high ambulatory practice expenses. We have faculty-based practice, hospital-based practices, I'm sorry. But in many cases, the faculty practices, the clinical departments were bearing very high ambulatory expenses. There were no particular incentives to grow the practices, even though the services were needed by the entire clinical enterprise. Too much unpredictability in the model, non-transparent negotiations between the individual clinical departments and the hospital leadership, unclear responsibility for practice performance, morale problems when departments and faculty felt they needed support but couldn't quite make the case, and a culture that was partially characterized by winning through negotiation rather than productivity, innovation, and quality. So that was the problem that we were trying to solve. And our guiding principles for the roughly year-long funds flow redesign, you can see on this slide, I won't read them all, but the key was that we would move to complete 100% transparency, and that we would try to create a high degree of accountability and a high degree of patient-centered performance. And we had as one of our primary strategic drivers at that time the need to grow the overall size of the clinical enterprise. I don't expect you to be able to read any of this, but the left-hand side of the upper was the pre-existing model with the various modalities in the medical center, the various modalities in the School of Medicine, and the faculty practice plan. And there were multiple arrows going in both directions with funds, and virtually no one in the entire organization understood it completely. We then collapsed everything under one governance and alignment where we had complete transparency so that anyone could see any numbers that they wanted to. And there was monies that went across into the academic side of the school. So we felt it was a much simpler model, more transparent, certainly promoted growth, was accessible and enabling to the individual clinicians, was flexible, supported all missions, and was financially sustainable. I won't go through this, but it is a model that we borrowed and then modified from places like the university, Stanford University, and others who had moved to a model similar to this with 4 tiers. I'll just point to 2 of them where we had a clinical incentive where we would share in institutional margin that was above the budgeted margin. And then we had clinical enterprise incentives that were goals to meet things like access, patient satisfaction, and quality. that were preset at the beginning of each year, and all of the departments could participate. Then finally, lessons learned. It paid to take a full year to work through with the clinical faculty their perceptions that this was somehow going to take away their autonomy and their entrepreneurship. There were concerns that this focus on alignment was going to change the emphasis of the university away from education and research towards the clinical mission. Staff who were going to move from individual department staff into the clinical enterprise staff were concerned about job security, and then making sure that the funds flow actually aligned with the individual department comp plans. There was initially great concern about whether this would be transparent and whether there would be trust and respect in the system, but our experience now, some 6 years in, is that effectively all of these challenges were met, and I think we all feel that the experience was a positive one, and I look forward to contributing to the panel discussion. So thank you.
Tony, shall I start?
Yes, go ahead.
Yes.
Hello, everyone. My name is Rob Hromis. I'm Dean and Vice President of Medical Affairs at UT Health San Antonio. And I'd like to walk you through our journey in reimagining our academic practice plan in light of patient preferences. Multiple patient surveys have shown that patients choose healthcare based on first convenience and then cost. Cost is often fixed beyond our control, but convenience is not. And so we embarked on a journey to become the provider of choice in our region based on convenience. So we started going to where our patients are. We created multiple self-contained primary care practices in neighborhoods across the San Antonio region, over 17 practice sites. We created a visiting specialty program in which multiple specialties hit each of these specific primary care clinics, the same specialty provider each time. And we didn't choose these locations by happenstance. We chose them by SG2 analytics, where there was the least physician coverage and the most patient need. And then we hired a large cohort of community health workers, something called promotores in Spanish, to visit our most complex patients in their homes to make sure they had transportation and medication compliance. This was fairly successful, but we hit the wall, and we needed to increase our access. And so we used 3 mechanisms to markedly increase our patient access. The first was systems engineering. What do I mean by that? Well, we mapped every clinic in relationship to every other clinic, all 65 of our clinic sites. We mapped them based on physician supply and patient demand. That is a lot of patients. Because when one clinic improved, it may harm another clinic. We found one cardiology clinic was borrowing an echocardiogram from another cardiology clinic. And so their access went up while the adjacent EP clinic went down. We also performed adoptive emotional reserve surveys in each of our clinics quarterly, because the emotional reserve of any given clinic could limit their access. And finally, we used predictive analytics to prevent no-shows. And we created a program via Epic to look at 22 parameters and then double or triple book those patients at the ends of sessions, not the middle of sessions. And our results were fairly good, as designated down below here. But we used other mechanisms to also expand patient access. We incorporated our community partners, and I'll tell you in the next slide why this became possible. We created a accountable care organization that is now evolving into a clinically integrated network that can track together with with each other for care. We merged with a number of different community private practices, and we call these charter practices. And they had specialist faculty ranks, assistant, associate, and attending physician. We didn't pay for practices. We did buy hard assets. We did assume leases, but we maintained location and autonomy for each of these practices. By extending our contractual rates, which were almost always better than their rates, we were able to cover the increased overhead of the UT benefits, the sovereign immunity, our marketing, and legal and compliance costs. And these charter practices in general made more than they made previously. And the reason why we're able to create these charter practices is because the town versus gown competition in San Antonio is really quite low. We're all collegial in the Bexar County Medical Society, and it's never really been a huge problem. However, what has developed in the last decade or two is a town and gown versus the for-profit hospital systems employing their own physicians. And this has become the new reality in San Antonio. And so we vertically integrated among our practice and then our ACO partners and then our charter practices by making sure that if we didn't have it, we created a joint venture with those who do. For example, the Texas Liver Institute had a huge group of hepatologists. Well, we had a huge liver transplant program. So that joint venture was very productive for both partners. We are starting an insurance product for our own employees. We hope to expand that to public employees. And then we horizontally integrated, and this was key, across all specialties. That meant that we could schedule directly into each other's clinic in real time. We extended Epic to all of our high referral community MDs, obviously all of our charter practices, our ACO members as well. And then we each had a Qgenda schedule and one-touch contact on our cell phone, so we had immediate communication. And by doing this, we've markedly increased patient access to all specialties, and we've markedly increased patient convenience because the portal for our patients is in 17 sites throughout San Antonio. Thank you very much. Look forward to the discussion later.
Dr. Patterson, you may begin.
Great. Good afternoon, everyone. My name is Cam Patterson. I'm the Chancellor at the University of Arkansas for Medical Sciences and the CEO of UAMS Health. That's the last slide. There we go. I appreciate the opportunity to share our experiences here at UAMS with everyone. How do I advance? How do I advance? Having a little bit of technical difficulty here. Give me a second.
I can drive your slides for you, Dr. Patterson, if you give
If
me.
you could advance to the next slide, that'd be great.
Okay, I will just request.
So I have been at UAMS for about 2.5 years. Over the past decade, I have experience in 3 academic medical centers, the University of North Carolina at Chapel Hill, New York Presbyterian Hospital, Weill Cornell Medical Center, and then the University of Arkansas for Medical Sciences. And I think as we have these conversations about the evolution in the way we deliver clinical care, my experience has been that it's important to understand that the structure of your environment is highly determinative of how much freedom you have to enact change that you need to make to adapt to the environment that you're in. For example, board reporting relationships are widely varied across academic medical centers. The relationship between the hospital and the physician's practice is different depending on whether you're a combined entity or, in the case of New York Presbyterian and Weill Cornell, two completely separate entities. And at the University of Arkansas for Medical Sciences, we are unique in the sense that we are the only academic medical center in the state. We are an extremely poor and extremely rural state. And we are a state with 2/3 of the landmass of the state actually depopulating. So access to care is a big struggle for the people of Arkansas, and has been part of the reason why delivery of care across the state has been so difficult. If you could go to the next slide. When I arrived at UAMS in 2018, I would say that we were in a difficult situation. After several years of losses, UAMS was on track to sustain a $72 million deficit in fiscal year 2018. Because of that, when I arrived, we went through a reduction in force, laying off 250 employees and eliminating 700 additional FTEs. And because of that, as you can imagine, employee engagement was in a dismal state at UAMS. Next slide, please. Our structure as of 2018 was, I would say, fairly disjointed in comparison to the journey that Sam described for UCSF. We were probably 10 years behind UCSF in our journey towards full integration. We had a single medical center in Central Arkansas in Little Rock. We had staffing partner organizations. We staffed the VA, Arkansas Children's Hospital, and Baptist Health, which is a not-for-profit private hospital here in Little Rock. But we did not have any partnership affiliation arrangements that allowed integration. We had 8 regional campuses across the state which delivered clinical care and also graduate medical education. But those regional campuses were not integrated in any way, shape, or form with our healthcare. And we were not on a single iteration of an EMR in 2018. If we could go to the next slide, please. So we began our journey to create a statewide healthcare system. This meant aligning all of our clinical programs across the state within our service lines. We are now on a single iteration of Epic. We have created a digital health service line, and we have added affiliated clinics across the state into our healthcare network. We now have boots on the ground in 73 out of 75 counties in the state of Arkansas. We have acquired practices primarily in Northwest Arkansas, Fayetteville area, and we have added practices in 15 additional sites across the state that were not present. In addition, we have digital clinics in virtually every county in the state of Arkansas, and we're able to provide both primary care and specialty care services through our digital platform for people across the state of Arkansas. Next slide, please. From a population health standpoint, I would say that we did not have a population health strategy when I arrived. We now have an ACO. We are just starting, or halfway through our 3rd year of our ACO. We basically broke even in years 1 and years 2. Over the first half of year 3, we're on track for over $30 million in Medicare savings. And we are in the process, as Sam and Rob talked about, of transitioning our ACO model into a clinically integrated network. Last slide. All of this work is being done in the context of our Vision 2029 strategic plan. The year 2029 will be the 150th anniversary of the University of Arkansas for Medical Sciences. And so our ultimate goal would be to have a statewide clinically integrated network providing services for any Arkansans who would need to access them in conjunction with about 850 other annual targets across our entire enterprise to support our tripartite mission for clinical care, research, and education. So that's a brief thumbnail sketch of what we have going on at UAMS, and I'm looking forward to participating in the Q&A. Thank you very much.
Dr. Strom, you can begin.
Yep, great. Can you pull up my slides? Great. As Cam had alluded to, certainly the different institutions, different situations are very different, and you'll see that again in as another example in my talk. So I'm going to talk about the future of faculty practice plans, again, innovative structures, imaginative approaches. Next slide, please. I am I'm the Chancellor for Biomedical and Health Sciences at Rutgers, and my mantra since I've been here, which is now almost 7 years, is to build one of the best academic health centers in the country with an emphasis on one. And I'll briefly explain why I make that focus. Next slide, please. RBHS, Rutgers Biomedical and Health Sciences, was created in 2013 by a law passed in 2012, which merged into Rutgers, a very large public university. Most of what was UMDNJ, the University of Medicine and Dentistry in New Jersey, which before that had been probably the largest biomedical university in the country. So almost all of UMDNJ came into Rutgers, and that part plus whatever health-related parts of Rutgers were in Rutgers before was put under a new chancellor position, which was ultimately mine. Next slide, please. So since 2013, with some changes, this has been our structure. And I won't go through it in detail, but atypically, we have 2 medical schools, one in Newark and one in New Brunswick, Robert Wood Johnson Medical School in New Brunswick and New Jersey Medical School in Newark. Multiple other schools under the same roof, and multiple centers and institutes. These are the major ones that report to me. A very large behavioral healthcare program. It's now about $300 million a year, giving behavioral health across the entire state. And then later we developed Rutgers Health. So New Jersey is in an unusual situation, a very compact, very diverse state. And again, Rutgers and UMDNJ were separate, and historically, Rutgers does a very good job of the whole being less than the sum of the parts. UMDNJ was even better at it. So these were multiple separate competing institutions, including the 2 medical schools, which compete with each other and were structured very differently. Next slide, please. Within UMDNJ, there were 2 very different faculty practices. At Robert Wood Johnson Medical School, there was the University Medical Group, a school-based centralized practice plan organized across the departments, reporting to the dean, primary care focused. Faculty and staff were employed by the university, billing revenue cycle and electronic medical record run in-house or by vendors, and an incentive system which was large for productivity, which was largely non-existent. People were salaried. New Jersey Medical School in Newark was the opposite. There was a university physicians associate, a separate corporation, separate from the university, the board of which were elected by faculty, but yet it was not part of the university. It was a decentralized, department-based practices, specialty care focused, almost no primary care, a separate nonprofit organization of UPA that provided staffing, clinical staffing, billing, revenue cycle management services, There were dean's taxes that went to support the medical school. There largely was no electronic medical record outside of the hospital. And then some of our other schools, dental nursing and health professions, had small individual practice groups. Next slide, please. What we did relatively early on after getting there, after I got there, was form a single Rutgers Health Group, a single integrated provider organization, 800 plus providers at that point, a separately incorporated subsidiary of Rutgers, with Rutgers as the sole corporate entity, a company with a board with fiduciary responsibilities, largely chairs and other senior leaders of the practices, and encompassed all clinical faculty. So all combined together into one medical practice. Next slide, please. And this shows at that point we were, now we're over 1,000 clinical providers in 16 of the 21 New Jersey counties and over 60 municipalities. And this sort of shows where we are, primarily in Newark and New Brunswick, but by no means exclusively. We're really spread out through much of the state. Integrating a course that has been a process that is still underway. We succeeded finally in getting rid of UPA. We're reconciling the incentive systems across the two medical schools, again, dramatically different in the two schools. Essentially no incentive system in New Brunswick, and in Newark, the faculty had a very small baseline salary and collected basically 50% of their collections, which is why Newark was very surgery based and New Brunswick was much more primary care based. Next slide, please. Also, can you, yeah, keep going again? Okay, also anticipating, nope, back one. Anticipating moving to population health, which had lagged in New Jersey. I talked about the Rutgers Health Group you see on the circle on the left. Rutgers Health was beyond that, the clinical brand for Rutgers and advisory to me in my role as executive vice president, and really represented all the patient-facing parts of Rutgers. So not just the parts that were faculty practice, but it included social work, it included clinical psychology, it included anything that was clinical that was Rutgers. More broadly than that, surrounding all of them was envisioned the Rutgers Health Network, including a clinically integrated network, partnerships with our partner hospitals, and the idea that we would cooperate with them in order to be able to develop a functional health system that we were a central part of. Next slide. We achieved that by partnering with RWJ-Barnabas Health. RWJ-Barnabas Health is New Jersey's largest academic health, now academic, wasn't before, healthcare system, the state's largest private employer, one of the largest health systems in the United States. 11 hospitals, it's actually about to be up to 14, close to $6 billion in revenue pre-COVID, and lots of deliveries. This does not include us. This was separate from us. We're about a $2 billion a year organization and in the academic center. Next slide, please. 2 years ago, we signed a master affiliation agreement linking the two of them. The shared objective to collaborate and form a world-class academic medical center that functions as one system. Next slide, please. Mutual goals to develop a world-class academic health system, to recruit leading academic research and clinical faculty, to consolidate clinical services under the RWJBH leadership while still respecting the traditional but accountable academic reporting structure that is faculty report to the chairs, chairs to the deans, deans to the chancellor. Dedicate collective resources, meaning mostly theirs, to education, research, and health improvement to benefit patients, students, and all of New Jersey, and uplift our GME programs to be nationally competitive and position us to retain the best trainees. Next slide, please. Clinical enterprise. So the goal is that the research and education would be under our leadership across the state, including all of their residents as well, and they would provide the clinical sites for all of our teaching, and that the clinical enterprise would ultimately move under their leadership, though still with the faculty remaining faculty and so on. So the vision was one strong, highly functioning, combined practice to meet the healthcare needs of the community, a financially sustainable, aligned clinical enterprise within what would become an academic health system that's fully supportive of education and the research mission, combining both their practices and our practices together. Next slide. led by an integrated practice CEO who would be a health system employee reporting directly to the health system CEO and indirectly to me. The senior vice chancellor, my senior vice chancellor for clinical affairs, deans, senior associate deans for clinical affairs, and our chairs would be accountable to the integrated practice CEO for the management of the clinical practices. Next slide. So what we did in this three-phase process, as you can see in the left, the Robert Wood Johnson Medical Schools University Medical Group combined with New Jersey Medical Schools UPA into the Rutgers Health Group. We are now combining, that's on the left side. On the right side, you see the RWJ Barnabas Physician Enterprise. They're being combined into the combined medical group. And last slide, please. Next slide. You see together, we now offer a vast network of clinical providers in 17 of New Jersey's 21 counties. That structure was just actually approved by our board yesterday. And so we haven't implemented it yet, though we've done a lot of the work toward implementation in the last 2 years. Thank you, everybody.
Thank you very much to all four of our panelists. That was fascinating. You know, we are living in a new era, certainly. Before we get started with questions in the chat, I had a question, certainly for Dr. Hawgood and perhaps for Dr. Strom as well. When you are, if you are in the position of primarily vice president and over a health system, how do you and your medical school dean jointly recruit clinical chairs and evaluate those clinical chairs? It strikes me that in this new world, we have very different expectations of our clinical chairs than what was expected of them 10 or 15 years ago. And to recruit a chair with a very, very strong scholarly background, you also need someone that really understands clinical ops and contemporary health systems. So how do you all work together? Dr. Hawgood, how do you and Talmadge recruit folks together for these roles?
Sure, thank you, Tony. So the responsibility for recruiting clinical chairs relies primarily with the dean, Talmadge King in our case, but is done as a coordinated effort within that box that we call the Office of UCSF Health. So it's a coordinated recruitment partnership with myself as chancellor and the president and CEO and the dean, and we work tightly together, both in the selection process and in the package. And I think the major difference, I would say, over the last 6 or 7 years, I would say there are two. One is what you pointed out. You're asking people to come in and run, large businesses effectively, and so they have to have that kind of management experience. And then second, which is even more important to me, and is, to be honest, where I spend most of my energy, and that is making sure that they're coming in with a very strong institutional bent. Yes, they're advocates and leaders for their individual department, whether it's neurology or neurosurgery or whatever, and they're accountable and responsible for that. But they are going to sit on the leadership council that is making the decisions on a $5 billion a year enterprise. And so they have to be, when they're sitting around that table, they have to be wearing an institutional hat. And so I test that pretty hard in the recruitment process.
Okay, thank you.
I would say our experience at UAMS and our practice at UAMS is similar to what Sam described, with the exception that we have some chairs who are both department chairs and service line directors, and in some circumstances, those positions have been separated.
Got it.
So for example, our chair of the Department of Orthopedic Surgery is also the service line director for the musculoskeletal service line. But until recently, the chair of OBGYN was not the service line director. So we sometimes feel like it's too difficult to have one person who has the business skills and developmental judgment for service line director, but may have the academic credentials for department chair.
Got it. Thank you.
Yeah,
Oh, go ahead.
yeah, and our situation is sort of, again, somewhat similar. Certainly the chairs are chosen by the dean primarily, and I have input. The health system has input. The issue of the fact that you need somebody, as you're alluding to, Tony, you need somebody who has both academic research skills and business skills is certainly an issue. There are departments that we just envision aren't going to be large academic foci. Their focus is to provide service. There are other departments that we really want to develop into research powerhouses, and it's different in our different. Keep in mind, again, we have two schools. They're very different. Two principal teaching hospitals. In Newark, the principal teaching hospital is a closed hospital of the medical school. In New Brunswick, it's not. And about a third of the admissions in New Brunswick are by private docs. And so there are areas where a lot of the clinical services are already being delivered by the private docs. And what we want for a chair is somebody who's mostly going to be developing academics. And then, you know, depending on the balance, you might have a chair who's a chair with a clinical vice chair, or if the chair is primarily research oriented, or a chair who's primarily clinical with a research vice chair.
Okay. And Brian, while you're on the screen, Dr. Romas had a question for you, Dr. Strom, on how you standardize the faculty salaries across locations to kind of prevent poaching. His word.
Great question. And of course, as typical in Rutgers, not a simple answer. It's more complicated because we have a unionized faculty. So standardizing salaries, comp, becomes that much more complicated because of the involvement of the union. The easy part was the eliminating poaching. I just didn't allow it. From very soon after I got here, schools weren't allowed to steal from each other between our two medical schools, or the other schools, because this wasn't just a medical school issue. With basic sciences, we had people in the pharmacy school and other schools that people wanted to steal one school to the other. That was not useful. We just cut that off. The equalization of salaries is still underway. So we put in place a clinical incentive plan. In general, the salaries, because of the lack of clinical incentive in the different specialties, the salaries in New Brunswick were lower than they were in Newark. We did a lot of ad hoc adjustments, but in addition, we put in place a clinical incentive plan that based on your percentile salary and your percentile productivity, if they didn't align, it would automatically adjust people to make that percentile equivalent. So it didn't make up for the people in Newark who were overpaid, but it made up for the people in New Brunswick who are underpaid.
It only went up. It didn't also go down.
That's correct. That's absolutely correct.
That union is powerful.
The union is very powerful. Didn't go down until COVID. Now, again, in COVID, the opposite obviously has happened. In Newark, it's gone down a lot. And with New Brunswick, on the other hand, COVID drove New Brunswick school into the red, where the Newark school was largely protected from that.
Okay. And there's a question in the Q&A for Dr. Hawgood. Sam, Mike Good wants to know how and where in your model do departments generate the funds that they need for their research and education programs?
So there's two major ways that happens if we're talking just about clinical funds. First, there is a sort of off-the-top allocation in the funds flow to the Dean's office for academic support, and in part, and using other funds as well, including philanthropy. The Dean has created a relatively centralized education funds flow, if you like, where folks who are doing the heavy lifting in education, not simply having a student on rounds with them, but the folks that are really driving the education side, both in UME and GME, paid centrally through an educational funds flow. And then the funds flow to the clinical departments, which is effectively an RVU, the majority of the money is in an RVU-based funds flow, which is a percentage that can move up or down of MGMA. And in general, the salaries are pegged to AAMC, so that creates a differential between the funds flow and the actual compensation that the departments can use. And it works. Our School of Medicine is the #1 recipient of NIH dollars in the country, and has seen, a fairly dramatic increase in our research budget over the same time as we've had this tremendous growth in clinical activity. But it was a very high primary concern initially, that this sort of focus on corporatization, if you want to use a bad word, of the clinical side of the house would cause irreversible damage to the academic side of the house. And I would say the opposite has happened.
Okay. And we have a question in the chat from Michelle Mariscalco. I hope I'm pronouncing your name correctly. In organizations that aligned outside practices, are there examples where you have aligned with the federally qualified health centers or public health clinics rather than specific physicians or clinical practices? And I
Yes.
guess that is for any of the panelists.
Yeah, so I can speak to our experience here. We have obviously in a poor rural state many FQHCs. We also have many rural hospitals that are distressed. We've been fortunate because Arkansas, in contrast to the states that surround us, did expand Medicaid. So we've not had hospital closures to the extent that Texas, Tennessee, and other nearby states have had. In contrast to the UAMS-based clinics, our relationship with the FQHCs and also the rural hospital network has been poorly defined. And part of our strategic plan is to change that. We created a rural health resource center for the state, in which we provide services for both clinical practices and for rural hospitals. We're in the process of rolling those services out. The first that we have rolled out is access to our EMR. So we are in the process of getting FQHCs onto our, who are interested, onto our same iteration of Epic, but we'll also be providing financial services, procurement services, and other support services, both for the clinics and for rural hospitals, with the idea that strengthens our relationship as we begin to move to an integrated network. We can then bring them into our integrated network fairly easily.
Yeah, we actually have probably 3 solutions at our 2 medical schools to addressing it. One, in New Brunswick, keep in mind everybody was salaried. We have a teaching FQHC. It may be the only teaching FQHC. That a very, very central part of our teaching program that is incorporated into the school. Whether our faculty are seeing patients privately or private practice outside that, or at the FQHC, doesn't matter to them because they're salaried. And so that's an easy approach. In Newark, where they have a very, very strong incentive collecting 50% of their collections, our principal teaching hospital is the only state hospital in the state, and a very poor population associated with it. And so we have a clinical services agreement with that hospital that provides substantial funding to the school, and the school basically uses that funding and it pays for percentages of faculty time to see those patients. The other thing we've done is we've made aggressive use of MAPS, a Medicaid program that basically increases reimbursement, Medicaid reimbursement, up to the level of private reimbursement. And so that basically removes the disincentive for our faculty. You can do that in a public school. I came from Penn. We couldn't do that at Penn, but we can do that here as a public school, and it increases reimbursements to be able to achieve higher reimbursement for the docs, even though they're seeing poor patients.
And honestly, that is absolutely, for those of us that have that mechanism, it's absolutely critical to funding our academic medical center. I don't know what we would do if we didn't have that that mechanism in place, because it really is critical.
And I go one step further. It's a big plus we can bring to our private health system partners.
Absolutely.
Part of what makes us attractive to them, and them giving us money accordingly,
Right.
is the ability to be able to tap maps in the process.
Right. I don't see any more additional questions in the Q&A. And so I think that we will go ahead and wrap up the session. Again, I want to thank our 4 panelists. Those were outstanding presentations, and I think we did indeed see great examples of innovative solutions and imaginative approaches. So I'm sure that we all gained a great deal from you panelists, and I thank you for your contribution. We are going to have people move to the next session, and that will be an update on the AAHC's President's Council work. And I believe, yes, and the AAMC staff has put a link to that session in the chat. So thank you for attending this session. It was great to see everyone. And I want to thank our panelists again. Certainly appreciate it. And everybody enjoy the rest of the meeting and have a great day. Bye.
Bye-bye.
Bye-bye.
Thanks, Tony.
Bye-bye.
Thank you.